who rather confusingly is titled as Luke Smith because we had a slight IT hiccup, but it is actually genuinely Nick. And Nick's going to be presenting and run us through some slides to introduce us to the world of flexible endoscopy. We have the usual chat on Teams and also Q&A. I'm not quite sure what the difference is, but if you wanted to fire over any questions, please do, and we'll pick those up at the end. We're recording the session, so we'll share it, we'll save it and share it through our YouTube channel as well. Final point is this is CPD accredited session, so after the completion of the webinar, your details will be sent over to CPD and you will automatically get a certificate through them for attending this, so which hopefully will be of use. If you regarding questions, if you have any ideas for other webinars that you'd like to, that you're interested in, then please please fire those in the questions. But without me taking up any more time, Nick, are you okay there? You ready to kick us off?
I'll turn off my camera. You don't particularly want to see me. But good afternoon, everyone. As Dan said, we had a couple of IT issues. So the positive side of that is I'm now Luke Smith, who's a lot younger and better looking than I am. But to really go into the presentation, give you an idea as to what we're going to be talking about today, it really is a basic introduction to flexible endoscopy. So 3 areas that we're really looking at. One is the endoscopes themselves, how they're designed, what the design criteria are, what the internal structure is and what the external structure is, where they're used, and then also looking at some of the damage that can occur to these instruments and how to prevent them, some of that damage. So let's, without further ado, let's go on. Dan, the presentation is not forwarding.
Okay, bear with us a sec. All right. One moment, another IT issue. 2 seconds, and we'll be back online.
Oh. That's not forwarding. Okay. Okay, apologies for that. I have my IT imp out today as my PC did not work at all. So first thing we're going to really talk about is define endoscopy. Endoscopy really is to look, microscopy, look at something small, endoscopy, look inside. And strange enough, use the term for what you use to look inside, in this case, is an endoscope. There are principally 2 types of endoscope, flexible endoscopes and rigid endoscopes. Flexible endoscopes were really designed to sort of follow the natural anatomy of whatever area you're looking at. So you could say that they're made really for God-made openings, and rigid were more made for man-made openings, but there are obviously exceptions to that, particularly with rigid and urology. But from an endoscope perspective, this is a flexible instrument, this is a rigid instrument, this is as you can see, there's an eyepiece at the top here, the distal end here. Used to be used principally for diagnostic procedures, and the rigid instruments were principally used for more therapeutic procedures. So diagnostic v therapeutic used to be pretty well black and white, and the flexible instruments were used in endo units, and the rigid units rigid instruments were used in theatres or operating rooms, whichever your nomenclature is in your country. So it used to be really quite black and white, but it's now quite grey. There's a lot of therapy done with flexible instruments. There's diagnosis done with rigid instruments. They're used all over the place, and you have also things like this, this is a laparoscope with a flexible tip. So it's a rigid instrument with a tip that can move around, and so obviously that gives some fundamental advantage to the operator in terms of this area here would normally be rigid and you'd have to move it very much like you'd use an instrument. But the fact that you can flex the tip means you could actually go behind the area of interest and look back on it. You could go underneath and look up. So it gives a lot of benefits to the operator. And from the flexible side, there's been more and more therapy done. This is a diagrammatic representation of procedures which were notes or natural orifice surgery. This was a procedure that was being mooted some years ago in the States, which was taking a gallbladder out through the stomach, the throat. That didn't take off totally, but there was a lot of interest in it from a technological development perspective and also from a surgical perspective. But the principal issue is with that was the limitation of the outer diameter. Obviously, the outer diameter of the instrument is small, and therefore, for example, scissors were a particular problem. Getting a small scissor through a small channel and then getting good cutting with it was proved to be quite difficult. But it's an illustration of how grey it's become. We're only going to be looking at flexible, so ignore rigid endoscopy, and principally what we're looking at is the endoscopes themselves, but I did want to highlight that they're part of a system. These are the endoscopes that we're talking about, the flexible endoscopes here, and really that's all we're talking about, but there are other aspects to it. So if I, excuse me, that's a fiber optic instrument with an eyepiece. This is a video instrument without an eyepiece, but you can see some buttons on the top, which I'll come back to in a minute. Because that has a chip at the tip of the instrument, you need to get the image back and then display it on a screen. So there's video systems, you need video processors, display systems, so high resolution screens are used. And there's also other aspects of flexible instrumentation. So you've now got endoscopic ultrasound. This picture is an example of an ultrasound picture that you'll see with a flexible endoscopic ultrasound system. The advantage of ultrasound through an endoscope, using an endoscope, is basically there's a fundamental problem with ultrasound in that the higher the resolution you get, the higher the frequency. So the higher frequency sound you use, the higher resolution you get of the tissues, but the lower the penetration. So by using an endoscope to get the ultrasonic transducer very close to the area of interest means you can use much higher frequency sound and gets much higher resolution. There's also magnetic imaging technology. This is an example here where this is a colonoscope, a flexible colonoscope, where you have magnetic coils inside the colonoscope, and you can then image how that is in the patient themselves. So if you get, for example, a loop, there's certain different types of loop, and by seeing how the loop is, you can then quite easily rectify the loop by using that magnetic imager. Another area where there's been a lot of technological development is in flexible accessories. So there's just an example of flexible accessories, whether they're for cutting balloons for either retrieval or dilation, and cannulas. So there's a lot of technology on this, and moving more to the therapeutic side of things rather than the diagnostic. And then you also have energy devices and cleaning disinfection systems. So we're ignoring everything apart from the endoscopes themselves. And if we look at the actual construction of a flexible endoscope, there's principally three issues, three parts to you have a handpiece, you have an insertion tube, and you have an umbilical. The handpiece is obviously the thing that goes in the operator's hand. The insertion tube, the name gives it away in terms of it's inserted into the patient, and the umbilical goes into the other bits, the light source, the video processor. In some countries, the umbilical cord is called a universal, so you may know it as a universal rather than umbilical. Fundamental to the construction, you have to have an optical system, and that is either a fiber optic imaging system or a video imaging system. The fiber optic system will use what's known as a coherent fiber bundle, where the individual fibers are stacked. So the top right hand side one is the top, the eyepiece is the top right hand side one at the distal tip. That transmits an image back via the fiber optic system, or you have a chip at the tip, so a simple camera chip at the end of the endoscope, which gives the optical image back from the area of interest. Obviously, most of these areas of interest are there's no natural light around, so you need to take light down there, and that's using a fiber optic bundle. And then you also want to move the distal tip around, and there's either 4-way or 2-way angulation. So you need to have angulation wires, and you need to have channel systems, unless you're just literally looking at something for an optical system. You need air water, suction biopsy, and there's some endoscopes that have additional channels, such as an auxiliary channel for extra flushing, or razor bridge channels, which I'll come back to shortly. So there's a lot to go into a system, to an endoscope. Excuse me. So the outside of the instrument, this is a diagmatic representation running from the distal tip, which is the most important piece in terms of imaging the area of interest inside the patient. There's a bending section, and this can be bent in usually a north, south, east, west way with these angulation knobs. You've got an up-down angulation knob and a right-left angulation. On smaller instruments, there's just an up-down. And then you have the insertion tube. And the insertion tube in many instruments is obviously very important in terms of the characteristics of that instrument. I remember, particularly with, for example, lower GI instruments for colonoscopy. I remember an early colonoscopist I spoke to many years ago who we were talking about the improvements in optics, and he said it's not an issue massively, because if you haven't got the right insertion tube characteristics, you can't get that distal tip to where you want it to go. So the insertion characteristics are very important, as are the optical characteristics of the instrument. And on some instruments, some colonoscopes, there is an insertion tube stiffness control. In colonoscopy, you sometimes need a flexible instrument, and sometimes you want it more stiff. And on some instruments, you can actually vary the stiffness of this insertion tube. This is the handle. This is the area where the operator will hold it and move the angulation knobs, also manipulate the air, water, and the suction, and potentially do a biopsy through the biopsy channel. I mentioned remote switches earlier. This is a video scope, and these can be pre-programmed to do a variety of things. Usually what you're looking at is for taking a picture, taking an image, or potentially changing an imaging format, which I'll also come back to in a minute. And then moving back, you have the umbilical or the universal, depending on which country you're in. This goes back to the light source and a connection to the video processor. So quite a complicated outer construction. The internal construction is a lot more complicated. This is an example of a diagnostic example through a colonoscope, and you can see the internal area of the instrument is absolutely packed with a variety of channels, wires, etc. You need a light guide to take the light down. There's a wire for adjustable stiffness in this case, which is a colonoscope. You've got 4 angulation wires. There's an air water channel. You've got the CCD wires here that take the chip signal back from the distal tip to the screen, and you have a biopsy and suction channel here. And the first sort of point in terms of potential damage, if you get fluid ingress into this internal structure of the instrument, it can cause a lot of damage, potentially very expensive damage. And that can be, for example, it could be this fluid ingress due to a problem with the bending section, so there's a hole in the bending section rubber, or it may be internal actually here. So for example, with this biopsy suction channel, if you're putting down some therapeutic instrumentation, for example, a laser fiber or a needle, and you have the distal tip of the instrument in a sort of a J, what was known as a sort of a J loop, then clearly there's bends in it, and if as you're passing that needle or laser fiber towards that, it will hit the wall, and if it's sharp, it can then potentially go through that wall, and you've then compromised your internal structure of your instrument that way. So we'll come back to that later, but the principal thing to remember there is it's very complicated internally, and if you get fluid in there, it's not good. To talk a bit more about the internal channel structure, that's a diagratic representation. Again, it's not to scale in terms of the insertion tube, showing the biopsy and suction channels and the air and water. And again, to use that as an example, I've just said, if you imagine this nozzle was bent into, sorry, this bending section was bent into a J shape there, and you're putting something down here, and it goes through the J, again, you can see that you will potentially get a problem there with the bend and the sharpness of the instrument that you're actually putting through the channel. So complicated internal structure. In terms of what do we really want to do when we design an instrument, I've been involved with development of some aspects of flexible endoscopy in the past, and the fundamental one is obviously how big is it. Once you've decided how big you want your outer diameter, and you then decide what you want to put in it, you may find that you can actually reduce the outer diameter. Generally, you find you may have to increase it, but you obviously want to keep it to a as small as possible from a patient comfort perspective. Then there's the direction of view. Most flexible instruments are actually forward facing, so it's literally just a straightforward direction of view, but there are some forward oblique. So it's, if you imagine your face in a forward straight, and if you forward oblique, sort of 30 degrees down, or side viewing. And we'll come back to the reason for a side view scope shortly. You obviously need light, and you obviously need to decide what type of optics, how important are the optics? Do you want the absolute very best you can have, or do you want to compromise the optics for more channels? What type of optics do you want? This is what's known as white light. That's a standard endoscopic image, but there are other imaging modalities now from various different manufacturers. This is an example of narrow band imaging. This is an example of fluorescence imaging, all with various advantages and disadvantages. You want to decide what the balance is between the diagnostic aspect of the instrument and what the balance is in terms of the therapy, what you want to do with it. A classic compromise, for example, is with an instrument that you, let's say for colonoscopic screening. So you're seeing asymptomatic patients who are presenting with no problems at all, and you find something. Your immediate compromise there is you want the best imaging possible for your diagnosis, but equally, if you find something, it would be very useful to then do something about it there and then. So you've immediately got a classic sort of balance between what you want to do from a diagnostic perspective and what you want to do from a therapeutic. How big are the channels? How many of them do you want? And then the very important fundamentals of cleanability and serviceability. Clearly, if it's not cleanable, it's going to be a very expensive single patient use item. And if it's not serviceable very well, or it's very expensive to service, that makes a huge issue into the cost over the life of that instrument. And fundamentally, price. The initial price is obviously critical, but it's the life cost which is also perhaps more pertinent. Putting that in context, if we imagine a simple, this is looking at the distal tip face on, and you can see the fundamental balance between therapy through an instrument channel and diagnosis through the optical system. So how big do you want that, and how big do you want that? You also have light guides, you also have water and air, and a water jet to spray the lens, but that's the fundamental a compromise between the two areas. how much therapy do you want to do, how good do you want the optical system to be. In some cases, for example, you could even have a 3D system where you actually have to have 2 optical systems. This is a case of having 2 optical channels, two biopsy channels, sorry. So this is the optical system here, and you have 2 channels for therapy. So you might want to hold something on one side and then do something with another. Another example here is that this is a duodenoscope for ERCP, which I'll explain later on. But I mentioned a razor bridge. This is a razor bridge here. So you have a razor bridge channel for moving the razor bridge, and a channel through for the instrument. This in this case is a cannula, and you can move this in this direction so you can target the cannula better to where you want to go, which in the case of the ERCP will be the papilla or the ampulla of Vata, which we'll come back to. This is an example of an endoscopic ultrasound scope. This is the ultrasound transducer, in this case what's known as a curvilinear transducer. That emits sound in that plane into the tissues, and then you have the optical system, and this is for fine needle aspiration. So you have a needle that comes into that plane, and you're imaging where the needle goes to your area of interest, and you take samples of cells with fine needle aspiration. This, I mentioned natural orifice surgery notes that was in vogue some years ago in the States. This was I thought quite an elegant development, which didn't become a product, but it was a prototype. And you can see you've got triangulation for better surgical. You can obviously grasp with something like that and then use the hook for dissection. You could put a laser fiber through here or all sorts of things. And this is the optical instrument, a section of the instrument, and these jaws will close for when you intubate the patient. So quite an elegant design. Unfortunately, didn't get to be a product as far as I'm aware, but certainly gives you an example of how technological development can really look at developing the therapeutic aspects of flexible instrumentation. And I know certainly from the colorectal surgeons that I've known over the years, if you could do full thickness excision through an endoscope, that would be a massive advantage. So that's really the giving you some information in terms of the internal structure, external structure, and the types of endoscopes that are really quite complicated, and certainly are in terms of the actual, for any given outer diameter, the technology involved is really state of the art. How are they used?
Sorry, Nick. Sorry to interrupt you. I just had a question came to mind from my perspective. When you talk about the fiber optics, are they the same fiber optics that you would get in a rigid scope in principle? For the light and
the issue is purely how they're stacked. So I mentioned it's called a coherent fiber bundle. So as I said, so if you imagine very simplistically fiber 1, 2, 3, 4, 5 at the top of the bundle, they will be in exactly the same order at the bottom. For light, you don't need that, so they're just mishmashed everywhere, and they're a lot cheaper to manufacture. So the the fiber bundles that provide light in a flexible instrument are effectively the same as those that provide light in a rigid instrument. They're just fused at the tip.
Okay, thanks. And my other idiot's question, the razor bridge. So yeah. Can you just explain that a bit more in terms of the terminology and what it means?
Well, it's effectively, if you like, a sort of a cupped hand at the tip of the instrument.
Right.
And it's connected to a lever, a control at the top of the instrument that's moved by the operator, that will basically, if you imagine a sort of a cupped hand and a wrist that's moving in one plane towards the body and away from the body. I'm doing it now without my camera on. So and that's effectively it. So okay. You can target the accessory you've got much better, because otherwise what you've got is a fixed instrument. You then have to move the whole part of the bending section to target that area, whereas the razor bridge gives you another level of control.
Okay, and that's something that just specifically on duodenoscopes, or is it on other scopes?
Yeah, well, there's other razor bridges in other areas, but from a flexible perspective, that's the principal one, and I'll come back to that in a minute when we talk about ERCP.
Thank you very much.
Any other?
No, sorry, that was it. Sorry.
Okay, stop me if there's any other issues as I go, or if I say something ridiculously silly.
No problem.
So let's look at some procedures. I wrote down a number here. There's obviously others, but I think these are the major sort of ones. The first 5 are GI procedures, so both upper and lower GI, and they are using larger instruments with larger length of insertion tubes. And then the bottom 5 are smaller instruments. So they have smaller insertion tubes in terms of length and in terms of diameter. So the bottom ones have up-down angulation, and the top ones have 4-way angulation, up, down, and left, right. But just moving through those, so as I said, upper GI, you've got scopes that go down the throat, through the anus, in terms of gastro and colonoscopy. ERCP is swallowed and goes into the duodenum to look at the biliary system. EUS can be used pretty well anywhere, technically, and then enteroscopy. Some people may not have heard too much about that. It's actually small bowel endoscopy. And then the bottom 5, bronchoscopy, cystoscopy, ENT, hysteroscopy, and procedures for difficult intubation by anaesthetists are all smaller instruments. So let's have a look at some of those. Gastroscopy, this is the patient position, and you can see this simply swallowing an endoscope. Some of you on the call may have had a gastroscopy. I have. It's really not that bad until the sort of lignocaine or whatever they use in the throat to knock out the gag reflex stops and you start gagging, but it really doesn't hurt, and if it's quick, it's very simple and straightforward. Swallow it check the esophagus into the stomach, and you usually look at the first section of the duodenum. This is an example of an endoscopic image in the stomach. This is an ulcer. That's an example of an endoscopic image in the colon, and colonoscopy has developed quite interestingly from sort of diagnostic procedure to a therapeutic, to more therapeutic, particularly from a cancer perspective. The problem with colorectal cancer is it often presents late. People are a little bit funny about talking about stools and poo and everything else. And if it presents late, it's a real problem. I saw literally last 2 nights ago a program on Bobby Moore. He died at 51. It was probably one of the earliest, most famous people to die of colorectal cancer. But if you can get it early, for example, here, if you can catch that at that level, it hasn't invaded anywhere, you can cure it. So there's been a lot of work on technology of how can we get this earlier. And in the UK, we're very lucky to have a screening, colorectal screening program here. So the idea is you'll catch it early and you'll see it using white light endoscopy. You could stage it using endoscopic ultrasound to see how far it's gone in. And then you could actually take it out if it's at an early stage. And that's done by a thing called EMR, which is endoscopic mucosal resection. And how that's done is a needle is put in, injection fluid with a dye, so you can see it better, to lift the area that you want to take out. You then put a snare around it, use diathermy to take that off, and then you take the tissue away using retrieval forceps. What that looks like actually with an endoscopic image, that's this is the blue is the indioglycoma, which is the dye used with the injection. This is the area you want to take out. You can see that looks abnormal. So you put a snare over that. You then use electrosurgery to take that off, and then retrieval forceps to take it away. And that's what you're left with. Now that may look a little bit horrible, but it's very highly magnified, and this patient is effectively cured. So the development in technology, both from an endoscopic perspective and an accessory perspective, has been significant in this area. I mentioned ERCP, so this is a diagrammatic representation of the procedure. ERCP stands for endoscopic retrograde cholangiopancreatography. To slow that down, endoscopic is using an endoscope, retrograde it's looking backwards, cholangio is the biliary system, and pancreatography is the pancreas. Pancreas is actually here, it's not in this diagram. So that involves both white light endoscopic imaging and fluoroscopy, so using X-ray. And the idea is you'll put a cannula in here, inject contrast dye for the fluoroscopy, and you'll see the biliary system and the pancreatic system. A good example of a common example of what happens is when you have gallstones, a stone might travel down the bile duct, get stuck here and cause a traffic jam for the bile, which then backs up and you get a dilated biliary system and you get jaundice. That can also happen with the pancreas if the stone goes down to the bottom here, which is the ampulla ovata, and it blocks the pancreatic duct as well as the common bile duct. Then you're not only blocking the bile, but you're also blocking pancreatic enzymes, the pancreatic juices, and that also causes a problem with pancreatitis. So this is a very common procedure, a very skillful procedure, and this is what you'll see if you were in the room, in the endo room with the operator. So this is the fluoroscopic view. So this is the X-ray view. You can see this, the instrument and the cannula, and you can see a dilated, looks like a sort of a tree system. This is the dilated biliary system. This is the endoscopic image, and you can see this is the stone here. Moving on to EUS. This is a diagrammatic example of an endoscopic ultrasound. This is actually a curvilinear transducer with a needle. This is an example of a radial image from a different. There's two types. So a radial image gives you that kind of thing, and a curvilinear gives you something like this. So you can. This is the endoscopic. The ultrasound and endosonography image. That's the area of interest. You can see this white line is the needle going into that area of interest a number of different times. So the needle technology has come on a lot, so it really does show up better on, so it reflects the sound better for better visualization of the needle tip. You take out the cells in the area of interest and obviously send them on to pathology. So those are the sort of the bigger instruments, if you like. The smaller instruments that I mentioned in terms of both size and in terms of diameter and length of the insertion tube. I've got a few here. There's cystoscopy or uterorenoscopy. So basically bladder, prostate, ureter, and kidney. That's an example of a uterorenoscope, which will go into the ureter. And a diagratic representation. The example I just used with the RCP with a stone is often the case in here, where you've got a kidney stone which migrates down the ureter, which is extremely painful. It then blocks the urine backs up here, and you get a condition called hydronephrosis, where the kidney is just full of fluid. So you need to fix that, and you introduce a flexible instrument in here and use either a lithotripter or a laser to break the scope, break the stone down. Potentially you can break the scope with it, and break the stone and then get rid of the fragments. So this is an illustration of that. Again, this is the fluoroscopic image where you can see the stone. That's the stone on the endoscopic image, and an introduced a laser fiber or a lithotripter that mechanically bashes the stone, breaks into pieces, which are then taken by a excuse me, by grasping forceps or snares, and then you end up with a nice clean ureter and the problem's fixed. Bronchoscopy used in the lungs. This is an example of a cancer in the lung. Diagnosis and some therapy is done in a similar way. So I don't want to go into lots of different areas. There are other areas that are weird and wonderful that I'm sure flexible instruments are being used, neurosurgery, for example, quite regularly. But those are the main areas that you'll see in terms of the instruments. And I want to then talk about the main areas of damage that can happen to those large and smaller diameter instruments. Obviously, the problem with smaller diameter instruments is they are as with rigid instruments, a lot less robust and more likely to be damaged. But let's look at some of the types of damage. First of all, mechanical, which if it's extreme will be shock damage. And a classic example of that is when you pick up an endoscope, unless you pick up an endoscope holding the distal tip, you hold the control section and the distal tip flops around naturally like a pendulum. And if it does that and then hits something sharp or hard, you can get damage to the distal tip. There is internal damage that can be caused by various therapeutic devices. There's more and more technology being developed in terms of what can go through a biopsy channel, but it can put pressure on that biopsy channel. And I've already mentioned, for example, putting a laser fiber, which is a rigid, fairly rigid piece of glass. It's flexible, but the tip is quite rigid, and that little tip can quite easily go through an internal channel. So it's, in terms of prevention, it's obviously being careful with the instruments, understanding that they are sensitive to shock, and for example, trapping instruments in an endoscope cupboard door, or in a case or whatever, are classic examples of things that the various endoscope manufacturers' service departments will see. There's also other types of damage. Part of the problem you have with flexible endoscopy is, as far as I'm aware, there aren't any autoclavable scopes out there yet. There's certainly autoclavable technology, because it's been around for some time, but I don't believe it's been commercialized from a cost economy perspective, principally. And there's a single patient use technology, so there's disposable endoscopes as well. But forgetting about those, how you disinfect, you need high level disinfection with these instruments, and the chemicals that do that, you have a fundamental problem that they need to kill the bugs, but they can't harm the humans, they can't harm the materials in the scopes or in the cleaning machines. And that's tough for the chemical manufacturers to develop something which will kill the bugs very quickly, but not really do anything else either to humans or materials in the instrumentation. So that's a common aspect of damage as well. But as I've mentioned 2 or 3 times already, the key thing to avoid is fluid ingress into the internal structure of the instrument. That structure, because there's so much in there. Anything, particularly if the fluid ingress gets to the chip itself at the distal tip, that's a very expensive repair. So to summarize, these instruments are complex, flexible, state-of-the-art optomechanical instruments. The cleaning, unfortunately, is quite complicated, and certainly not as simple as simple rigid instruments. These instruments are expensive, both in terms of initial costs and ongoing costs, and care and maintenance therefore is important, because they are all breakable. There are many different forms of damage, and minor repairs are literally hundreds, not too bad, but major repairs can be significant, and all you need is 1 or 2 major repairs to really blow a repair budget, which is why most manufacturers now offer, I believe most manufacturers offer service contracts to get over that sort of up-down problem from a budgeting perspective. But what you want to avoid, and what the manufacturers want to ensure you avoid, is fluid ingress. And certainly, to my knowledge, I think most manufacturers have care and maintenance teams that will help you with training. So really, whatever your endoscope supplier is, use those teams as you need them, for both from a cleaning disinfection advice and from a care and maintenance perspective. And that should, better training will prevent a lot of those expensive repairs. And prevention really is the issue. And I leave you with a quote from Albert Einstein, which is, "Intellectuals solve problems, geniuses prevent them." You won't get any thanks for preventing something because no one perceives that anything's been prevented, but by preventing a lot of issues, you will save the hospital huge amounts of money and keep the uptime up for the clinicians and the patients. That's it. Thank you.
Great. Thank you, Nick. Just I've tried to encourage people to send over any questions they have in the chat. So please do that before we finish up. Just one I had from my perspective was just, obviously you mentioned fluid ingress a few times and the potential damage. And I don't want to put you on the spot, and rightly so, you've referred back to the manufacturers. But is there anything particular that tends to cause that as a major contributing factor?
Well, it's either in, as I highlighted earlier, it's either internal, so you've done something to the channels, or it's external, usually in the bending section. And you can test with leak testing, and again, your endoscope supplier will be able to give you advice on leak testing, because there's a lot of different ways of leak testing, either using fluid or either using air blowing it up. And I'm sure, depending on the manufacturers, they'll say one is better than the other. I'm not going to make a comment on that, but you know, that sort of thing will be, just leak testing will prevent, hopefully, those you know, very expensive fluid ingress issues. It's with video scopes, it really is the chip. If the chip goes, it can be a real problem. If you take something like the uretoscope that I mentioned, the flexible urete that goes into the ureter and the kidney, you know, if you ruin the optical system in that, you're talking pretty well the cost of the instrument.
Yes.
So it's a big problem.
Yeah, of course. We're sure we want to avoid that. We haven't had any questions come through.
I've
couple of comments.
Gone too fast,
yeah.
or there's an IT problem, they can't hear me.
People are still trying to work out why it's Nick speaking and says Luke.
Luke,
That's
yeah.
probably. So another one from my perspective, robotics, you sort of touched on. Have you seen any robotic solutions that are coming into this field?
Well, interestingly, we were both at Medica last week, and there was a paper there that I read about with robotics, and there's no reason why, I guess, with AI developments, you couldn't do a robotic endoscope, but what they were principally talking about was developing with nitinol and you know, memory alloy, moving through that way. And they were also talking about a single patient use instrument. So my initial sort of thoughts on that would be, I'm sure you can get the technology there. Whether you can get the technology doing it that's reproducible, you'd have to do a lot of validation on that and a lot of research. But even if you've got all that, can health systems afford that kind of expense? Because even if you make it relatively inexpensive, it will be a very high cost per procedure. So that's, you know, that's part of the problem with this. It's you've got a balance between the sort of the cleaning and disinfection reality and consequences in terms of cost of repairs, and the optical performance of the instrument. Obviously, if you make something single patient use is always that problem. You want it's difficult to make something where it's a pair of scissors. You know, if you're going to make an endoscopic pair of scissors that go through the scope, and you're going to make them really cheap, then they're not going to cut very well. So you've always got that balance.
Well, yeah, because that I was thinking when you were discussing about the damage and you know, potentially the insertion tubes. Over the last few years, the sort of accessories for flexi endoscopes, and this isn't something that, you know, I have my own experience in, but I understand that cleaning brushes and things are very, very cheap, and you have a very, very expensive item, yet you're using very, very cheap items or trying to get cheap prices on these, and it doesn't say the two shouldn't really go together, should they?
No, it's a classic example of the problems that you have, you know, balancing the cost and the practicality of that. I mean, a cleaning brush is a good example. You can get some brushes, and I don't even understand how they can make them, let alone sell them for those prices. And obviously, if the brush head is good enough, then fine, but it might not clean it that well. The brush head might come off in the channel, and then you've got a problem. You know, I've seen all sorts of rogues gallery kind of examples in my previous life with an endoscope supplier. But again, you understand the pressures on budgets.
Yeah. There is a couple of comments just come on. Gemma has just mentioned that she was at a conference yesterday with ASP, who I gather some sort of sterilising company, and mentioned that they've got a low temperature sterilisation for rigid and semi-rigid scopes, and they're coming up with a solution for GI, hopefully in the near future, using hydrogen peroxide and plasma, which would be hopefully a solution to water ingress. So obviously taking away the risk would obviously improve the situation, I guess.
Yeah. I mean, and obviously the problem with them from the manufacturer's perspective is they will have to test that significantly before they could say, yeah, it's okay. And it's a bit like, I mean, I used to use the example of, I don't know, Levi's with jeans, and they're constantly getting this detergent manufacturers launching new detergents that actually have a problem with cotton, because a lot of the stronger as a general sort of case, the stronger the chemical is in terms of killing things, it's usually worse on materials. And I don't know for a fact, but I would imagine that there's three main flexible endoscope manufacturers, and they probably won't use all exactly the same materials, and so they may have individual difficulties with a new detergent or a new disinfection method.
Sure.
So that you need to speak to not only the supplier of the disinfection, but you need to speak to your endoscope supplier as to, has that been validated?
Yeah, understood. Another question on here, just around about the lifespans of flexible scopes. Like, how long would you expect them to last? How often should they be serviced?
That's an interesting question, because that from this country.
Yes.
Yeah.
Yep.
And in the UK, instruments, we actually did a study on them many years ago, and instruments last a lot longer, and they use a lot more patients in this country than they are in the rest of Europe. And it basically depends on if you have the scope on service contract or not, because if you have a scope on service contract, it should be getting serviced and also repaired regularly. And I've mentioned before Trigger's broom on Only Fools and Horses, where you've got the handle and the brush, and if you do a lot of damage to an instrument over a period of, say, 10 years, there's a lot of there's a lot of the instrument that is no longer the original. So you've replaced quite a lot.
So you're assuming we've got lots of Only Fools and Horses watchers out there?
Well, yeah.
Trigger's broom is.
Yeah. Well, hopefully there will. There's maybe some people from other countries won't, but it's essentially a handle and a brush, and you get 15 new handles and 15 new brushes and think it's the same instrument, and it isn't.
Yeah.
So it depends really on that. In terms of lifespan, I think if you've got something on a service contract, it's certainly often used 10 years plus. Whereas when I was in the States, I mean, they had a lot of instruments that were on 3-year leases that came back after 3 years, and to me, that's a bit of a waste of an instrument that is perfectly reasonable after 3 years.
Understood. And someone's just mentioned about, can we go into 17664, ISO 17664 on chemistry? Well, unfortunately, we can't on that, because that's not really our area of expertise. But if we do another one of these sessions, be happy for somebody to join us who has that X level of expertise and perhaps could field questions around that. Another question around disposables. So that's something we've seen a bit of. Do we have any knowledge of disposables? And
are you talking about disposable endoscopes or disposables through the scopes? Disposable endoscopes.
Disposable endoscopes, yeah.
No, I mean, I know they're out there, and I'm not going to make a judgment. I'm sure it depends on who you speak to. If you speak to a multi-patient use manufacturer, they'll say single patient use is rubbish, and vice versa. To me, the fundamentals are the balance between the performance and the cost. And the other factor that we haven't talked about is obviously the green aspect. There's more and more emphasis on the green ramifications, and clearly if you've got something you're just throwing away, that's not very green. But equally, there are, I'm sure, if SPU people on the call, they'll have arguments as to why SPU is the best.
Yeah, and I guess if you're taking those materials and then you can then recycle them, and perhaps they're then used for something else or used to make something else, then that sort of changes it a little bit. That industry seems to be being created as we speak, really, in terms of the circular economy and using parts that would be perhaps often discarded or just put in clinical waste. So that'll also be interesting to be seen.
Yes, and I think that will happen massively. I mean, I was literally, my vacuum cleaner battery is gone today, and I have to throw that whole thing out, and all it really needs is a battery. And it's Dyson. So that's nuts, and that'll change in all industries, I'm sure, over the next few years.
Yeah, agreed. And someone just made Gemma's just made a comment around sustainability being better as long as the medical devices are decontaminated through a validated process, which, of course, is a valid point. Obviously, everything has to follow a validated process. I did have another question, and I mean, obviously, what you described initially, the designs, extremely, the levels of technology are extremely high in perhaps scopes that have been used for a number of years, and it's quite mind-blowing to see certainly the number of channels, the number of instruments that can be used down them. I mean, obviously, technology is only gonna progress, which has to be good news for detecting cancers early on, I guess, Nick. So, and things like the pill cams, is that something that is that what you described earlier regarding the
I didn't mention pill cams. I mean, that pill cams are generally used for endoscopy, and you swallow a pill. The technology is, I mean, the miniaturization technology that the manufacturers have now is quite mind-blowing. But the issues are obviously you swallow a pill, you get the images through it, but when you see something, you can't do anything about it. And in this situation, it might often be a bleed. So the patient is presenting with symptoms of a bleed. You do an upper endoscopy, you can't find any bleeding point. You do a lower endoscopy you can't find any bleeding point. So the bit in the middle is where the bleeding point is, and you swallow a pill, you can find it, but you don't actually know where it is. So again, there's pros and cons, but the technology is spectacular, and I'm sure most people would rather swallow a pill than have an endoscope swallowed or put up the other end. So, but again, sorry,
no, I was just going to say, of course, you got with all these scopes, you've got prep factors as well, haven't you? That before and after that you have to prep, what you have to do and to prepare for having these in terms of like the preparation, which are also generally quite unpleasant, I suppose.
Well, I've had a number of colonoscopies as well, and personally, and I can say that the bowel prep is worse than the actual procedure. So, and with virtual colonoscopy, which is using X-ray, that's quite uncomfortable as air is inserted. So there's pros and cons of everything, strangely enough.
Yeah, of course. And I think in terms of bits that I'd written down as questions, one more question just around again, maintenance, optimum time, like how the frequency of maintenance checks. I guess that's quite similar to the previous question, but I mean, you just follow, ideally you'd follow the manufacturer's guidance on that.
Absolutely, but I think from a it also depends on the manufacturer that you're using and what country. There's some countries have guarantees that are quite long on a new instrument. And if you then decide not to have a service contract on that instrument, then it's very, very wise to have it checked out free just before it comes to the end of its guarantee, for example. So, but I would get it serviced regularly, and that should minimize. So, for example, with the angulation wires for moving north, south, east, west, the tip, they will start to slip. And if they break, that's an expensive repair. If they don't, if you notice there's a problem before they're going to break, that prevents an expensive repair. So there's a number of things that you can do. a regular basis in terms of servicing maintenance. But I would get them done at least once a year, maybe twice a year, and hopefully that would prevent some of the major sort of issues.
There was I mean, they specifically, they actually just added, since Nihao has said, what should be done when all the fibres are lost, I'm guessing, with the light. So that's just a repair job, presumably, is it?
Yes, I mean, if you, I mean, that's the same with the rigid instrument as well. I mean, yeah, if you can see the light, if the light is really not coming through, and the operator will be saying it's what's going on, turn the light up. Yeah, you can get that in, and it'll be a replacement fibre bundle for the light guide, for the light.
Okay, Nihao, hopefully that's answered your question. One final thing for me that I did think of and then immediately forgot. Obviously, we talked about different technologies like 4K, 3D, and is there any problems that present with improving the technology and the visualization of the site? Our understanding of the anatomy, colours, and that sort of stuff. I mean, can that be a complication sometimes?
No, I don't. I think it. I mean, the obvious sort of thing that first happened with 4K was the amount of data that you have in an image in comparison to a standard definition image, for example, is huge. So if you're recording, it takes a lot more memory, but that's soon been sorted. There are other types of imaging, as I've highlighted, and that goes up to improve. I think the only thing to probably put in context is I see it as being a bit similar to digital cameras. Digital cameras when they first came out were wow, and then the number of megapixels you had in your camera made a massive difference. After a while, there's a law of diminishing returns, and having 400 instead of 300 doesn't really make that much difference. I don't think we're at that stage yet with endoscopic imaging technology, but certainly we're on that sort of phase where I think it's made a massive, the difference between standard definition and high definition was huge. And then the difference in high definition and 4K was big. But I don't believe that that's going to continue to happen in a linear fashion. It will certainly go off and level off.
Okay, very interesting. Well, I think that's concluded the questions that we've had come in on the chat. I'll just check there's nothing on the Q&A because that apparently is another section. Okay, there is a couple more. So somebody's just said, Nigel said, did you favour brushes or specifically sized pull-through devices for clearing internal lumens? I mean, I don't know if that's something you're able to answer, Nick, but
no, I think
got any experience?
No, I would literally ask. I would refer that to the supplier, because it depends on what the instrument is, and they might have a specific recommendation.
Right. Okay. Yeah. So it all depends on the scope, of course, as well. Yeah. And yeah, okay, understood. And I think that's about it. A few people have asked around certification, and yeah, if you can add in your colleagues' details, if there's more than one person sitting on it, I need names and email addresses to be able to issue those certificates. So please send those across. We can share a copy of the slides as well, and this, as I say, the recording of this will be going onto our YouTube channel, which we'll share in the coming days. So, providing we've had nothing else come in, then Nick, thank you for the presentation. Very, very interesting, and we'll be doing another session in the new year. That we're not quite. I think last session we did around rigid scopes, Nick. But I think that's perhaps one we could go through again. So yeah, please look out for that. Thank you for your attention. This definitely works better on this Teams format. I think we've previously used GoToWebinar, which I think we're both equally poor technology-wise on both fronts, but this seems to be the favoured option, I think. So, great. Okay, well, thank you, everyone, and good afternoon. And I will send over the details as everyone has asked for shortly.